Episode 519, the current state of primary care, inevitable or fixable? Also, advice. Today, I speak with Dr. Lisa Rosenbaum.
American healthcare entrepreneurs and executives you want to know. Talking. Relentlessly seeking value.
Hello, all you Relentless tribe members. Today, let's start here. Right now, we are watching a very visible exodus of brilliant, consummate primary care and other, honestly, physicians leaving traditional practice for concierge medicine or otherwise. And look, it could easily be argued that the rise of concierge or direct primary care and otherwise is a symptom of a profession that has been decimated by structural forces. I mean, no one would need to go outside of the status quo if the status quo served their needs and or the needs of patients. So today, we, meaning Dr. Lisa Rosenbaum and I, are looking at the realities of primary care. And I want to be incredibly careful not to lump all primary care docs or other primary care clinicians into one homogeneous group. There are still those, especially in rural areas, who continue to practice wildly broad spectrum medicine. They're doing podiatry procedures, sewing up wounds, some oncology care, and their next appointment is a women's health annual exam. But for many employed physicians, they are caught in a structural framework that they really did not ask for. Many doctors really find themselves kind of forced into these models by the health system corporations that employ them. And the reasons for this mostly boil down to financial ones. Listen to, there are so many episodes where this gets discussed. You could start with episode 504 with Ryan Jacobs, episode 473 with Dr. Kenny Cole, episode 391 with Dr. Scott Conard. All of these shows hit this, it's all about the Benjamins, baby, from a myriad of angles. And I wanted to have Dr. Lisa Rosenbaum on the podcast today because she was the host for a whole series of shows on her New England Journal of Medicine podcast, link in the show notes, about primary care. She did a whole series on primary care that I wound up listening to after Dr. Amy Scanlon suggested I get Dr. Rosenbaum on the show to hash out some takeaways from that series. And that is the backstory for how this whole thing happens. But these takeaways, I kind of wound up summing them up in a very high stakes, frankly, kind of game show I'm going to call, is it inevitable or is it some kind of needless suboptimal inefficiency that we should all get to fixing? I asked Dr. Rosenbaum to weigh in on 3 categories of force majeures that are pushing against primary care in this country today. So the first of these 3, is it inevitable or just a needless inefficiency category that we hit, is a tough one to talk about and might have some strong feelings for good reason, but it comes up from a whole bunch of different directions in that New England Journal of Medicine series. So we'd really be remiss to skip over it. So yeah, we're talking about the old so-called cognitive atrophy. When you force brilliant physicians to stop using their judgment and doing what it takes to form relationships and earn the trust that goes with those relationships and really get to know their patients, and instead just double down on checking a whole lot of boxes. And if every procedure gets referred to a specialist, clinical skills can go dormant. Volume matters. As Dr. Lisa Rosenbaum today points out, if we are not careful, we could be facing a generational loss of some really key primary care skills. Because you might have your older PCPs who just continue to do what they are really good at, but younger doctors may find it harder and harder. And then Dr. Rosenbaum answers is this inevitable? No spoilers, you need to listen. Second category we tackle here is full spectrum clinical scope versus PCP's value mostly being their ability to refer into profitable service lines for a health system corporation. And listen to all those episodes I mentioned earlier for a much more robust and nuanced discussion of the financial whys here. But it is nearly inarguable that the system is structurally optimized to force early and frequent referrals in many, not all, many cases. And there's good reasons for this and not so good ones, right? I don't think anyone thinks it's a good idea for PCPs to do like valve replacements. Medicine has advanced since Perry Mason, and no one wants a world where what good looks like is a PCP doing something that these days you really need a subspecialist for. But is current state inevitable or a needless non-Goldilocks inefficiency? Stay tuned for Dr. Rosenbaum's take after talking to as many folks as she spoke with in that original NEJM series. Third category in our show today is transactional fragmentation, not longitudinal, relational, whole person care. Is fragmentation inevitable or just needless inefficiency? I mean, often enough, we have traded the relational expertise of having a doctor who knows a patient over time for fragmented algorithmic throughput. And what happens? The average patient ends up bouncing between something like 8 different specialists and using the ER for the most expensive primary care money can buy. When that happens, they become stuck in a downward fragmentation spiral simply because nobody is really quarterbacking or taking responsibility for those patient outcomes, the whole person patient outcomes. But yeah, again, listen to the conversation that follows for where we wind up in this third category.
Hi, this is Scott Conard. One of the highlights of my week is when Relentless Health Value comes out. I love to listen and then to think, who can I send this to that it would bless them and tremendously help them think through and solve a problem they're dealing with. It's, again, one of the highlights of my week, and I hope that you'll join me in appreciating and sharing Relentless Health Value.
Okay, I will give you one big spoiler, so earmuffs for all those opposed. But I've been thinking about it since I talked to Dr. Lisa Rosenbaum, and also while I was prepping for my conversation with Dr. Suhas Gandhi, which is coming up here in the next few weeks. But I found it pretty interesting that Dr. Rosenbaum, in my conversation with her, unprompted, she says, and this is the short version, hers is far more eloquent, but Dr. Lisa Rosenbaum says, and I'm quoting her now, if we just blame everything on a structural inevitability, we strip ourselves of our own agency. Interesting. My guest today, as I have said approximately probably 19 times already, is Dr. Lisa Rosenbaum. Dr. Rosenbaum is a cardiologist at the Beth Israel Deaconess Medical Center. She also works for the Smith Center there, which is tied to the BIDMC. She is their writer in residence. Also, Dr. Rosenbaum is a national correspondent for the New England Journal of Medicine, where she hosts the podcast Not Otherwise Specified, which recently, as aforementioned, dedicated an entire season to the state of primary care. I'm Stacey Richter. This podcast is sponsored by Aventria Health Group and also this year's series underwriter PayerSet. Check them out. They have a new 2026 price transparency field guide available on their website. I also very much want to thank Patient Rights Advocate for a really nice donation to help support our work over here at Relentless Health Value. Thank you so much, Patient Rights Advocate. Go to patientrightsadvocate.org. There are some really great resources available there for free. So let's get to it. Here is my conversation with Dr. Lisa Rosenbaum. Dr. Lisa Rosenbaum, welcome to Relentless Health Value.
Thank you so much for having me.
Before we get into the conversation, why did you do that series? What was the impetus behind doing an entire season on primary care?
I think it was one of those things where once I opened the lid, I just couldn't stop looking. I had an experience now nearly 2 years ago. A friend of the family asked me for a primary care physician recommendation in Boston. And I very quickly knew that if he wanted to be seen within a year, would have to get a concierge doctor. Because I'd heard that there were no primary care openings in Boston for at least a year, which was consistent with my experience in trying to get my own patients primary care doctors. And that felt like an inflection point. That was not something I had experienced before, and it felt like a big deal. And it was happening alongside watching an exodus of physicians I really respected, not just in Boston, but across the country, kind of in my networks, leaving for concierge medicine, and not physicians like who I might have assumed would have been the phenotype in the first place. These were people like consummate internists. And, I'm always trying to bring to my writing and the podcast sort of the things that science can't quite cover, because I have to complement what the New England Journal is doing. So it felt like a cultural moment. And once I started researching concierge medicine, it quickly became obvious that you couldn't understand this inflection point without understanding what's happening in primary care in the first place. That concierge medicine was in fact a symptom of what was happening in primary care. And so that's how it all started.
As I was listening to that series, I kept reflecting on a sort of a fundamental question. And not like this was a game show or anything, but I kept thinking to myself, is this inefficiency or is this inevitable? Like, does this have to be, or is this something that we're just not thinking about it right? And therefore, if we did switch up the paradigm or whatever, it wouldn't have to be the way that it is. So I appreciate you participating today, Dr. Rosenbaum, because this is what I would like to do. I'd like to tee up 3 sort of very large concepts and then ask your opinion on, is it inevitable or is it sort of needless inefficiencies? So
that's a great framework. I'm excited.
Wow. Prepare yourself.
Okay.
Here's the first one. So you did spend several episodes talking about and talking around this topic, cognitive atrophy of clinicians. We talk about practicing at the top of the license, but if you're not practicing at the top of your license for long enough, then it becomes sort of hard to practice at the top of anybody's license because these skills go dormant. So could you just explain that a little bit more? And then I'm going to ask you does it have to be this way?
Right. So I think that a lot of what we're seeing in primary care landscapes, not all of them, but a lot of them, especially in large corporate systems where people are under pressure to get through a visit in 15 minutes and also to go through a checklist by which a lot of their value is measured, is that people are responsible for a host of preventive measures or population health metrics like blood pressure management, diabetes management, cancer screening, things like that, or even like screening for social determinants of health. So those are things like the more algorithmic it becomes, the less you really need somebody who's trained as a physician to do it. And to go back to sort of this cultural moment I was witnessing and why I was so taken by this exodus and also the types of people who are exiting is because a lot of them fit into this archetype that I have like long internalized. I'm a 3rd generation physician, and there's something about a brilliant internist that I think exudes this idea of like just utter competence and brilliance. And I think if we really understood what makes for a good doctor, we would do a better job making everybody really good doctors. There's a judgment, there are instincts, there's a breadth of knowledge, and there's also just this like human kind of intelligence. Like maybe sometimes it's what we call emotional intelligence, but I think it's deeper than that. And a way of being able to sort of understand not just like multi-system disease and how that's playing out in any one person's body, but how it fits into the broader constraints of a person's life. And also, and this is like a dimension I think that we rarely talk about, how caring for that person is part of being part of a larger healthcare system. I think a lot of people, when they express frustrations with our healthcare system, it's because care feels fragmented. You hear that all the time. What an internist does, really good ones, they're quarterbacks. They know how to take what any specialist says and communicate that to a person, but not just like, this is what the cardiologist said, they want you to be on a statin. Also like, yeah, the cardiologist wants you to be on a statin, but I know you well enough to know you don't believe in statins. So we're going to come up with something. And like, that is a skill set that I am so worried. Part of why I was wanting to write about this in the first place. And I think what you're getting at is like, if once we lose that, it's very hard to get it back. But I will tell you what I really worry about is a generational loss. So I think to develop these skills, like anything in medicine is an apprenticeship. And so to recognize the importance of practicing in a certain way and to sort of mimic that behavior in somebody you respect, you have to be exposed to it. And so more than anything, it's less that I'm worried about like the 70-year-old internist in practice in rural Alabama is going to go through a bunch of checklists in a visit and forget how to be that internist who can do everything. It's more I'm worried that the trainee who comes to the clinic and precepts with him or her isn't going to have an idea of what that could look like. And that's a different type of cognitive atrophy.
What I'm taking away, this could be a generational issue more than any, as exactly like you said, like someone who practiced medicine in the before times, suddenly forgetting how to do it. But the fact is, because of maybe the structural constraints around them, if you have a 15-minute visit, and I hear this a lot actually from clinicians where somebody comes in with a horrible something or other, like norovirus. They're like vomiting all over the place. And then these things pop up that says, ask him if they got a breast cancer screening, right? Like it's just sort of like inappropriate.
It's wildly inappropriate. You're right.
Wildly inappropriate types of things. But like if that's happening, and then what good looks like is, did you actually ask the question? You can definitely see there's this term moral injury that we've all heard and has taken on
a life of its own. I will say it confidently. People use it indiscriminately. But in this case, I think that is a type of moral injury.
Right? Because you're like, I'm doing what's right for my patient. And then I walk out and get slapped on the back of the head.
I think it's more relevant when you think about like family medicine and procedures. So if you're someone who's trained to do some podiatry and work in the uterus, for instance, because you're a broad spectrum family medicine doctor, and then suddenly you're beholden to these like mindless checklists, and that's how you fill your days, of course your skills are going to atrophy. And so I think that that's a more clear example. And then I think my hesitance and just saying like it's universally happening is through my reporting, I just saw such heterogeneity in how people practice. So I agree with you. I think there's a risk to the people practicing now of cognitive atrophy, of procedural skills atrophy. Like we would never allow a surgeon to like spend their time going through a mindless checklist. Like that would just be absurd, right? So why are we doing that to other doctors?
Yeah, and just the practice of that happening, right? Like if I'm really good at doing whatever I'm doing, I am advanced, and then I sort of have to go through this checklist, or I have to do things that I sort of know. Like I often say, you can't process your way into judgment.
Right.
But
right.
if the process starts to take on prominence and my judgment is completely like, why would I read the latest studies? I'm not using them anyway.
For the last year and a half, I'm at a different institution and I'm not seeing ICU patients. And I can feel my instincts for critical care eroding. So like just not using those skills, that type of judgment, the familiarity with all the pressors and like the vent settings and all those things, like I'm not probably as good at it as maybe I had been when I was doing it all the time. That's like a very sort of rational and predictable thing that might happen to all of us. And yeah, I feel it happening in myself in just a different area of medicine.
Yeah. And underlining the point that you made a couple of minutes ago about how depending on where you practice and the patient demographic that you tend to see, primary care, it looks entirely different if you're in a rural, you're doing oncology and, sewing up wounds. It's a very different practice than if you're in some suburb where everybody pretty much just comes in looking for a referral.
Exactly. And that distinction is so important, and it's so easy to just lump everyone together. But I'm like, I don't want to act like all these people out there are not practicing like broad spectrum primary care still, because a lot of people really are. I think there's like another kind of type of doctor too that I got exposed to in the reporting who just shuts out the noise. Like that's how I think of it. They're just like, this is dumb and I don't really care about my metrics. Like I'm good at this. I know I'm good at this. I'm beloved by my patients, by the institution. I'll just do what I need to do. And that's not possible, especially for a lot of young people at the beginning of their careers. But I think that's just another type of rebellion that is sustaining primary care in its own weird way.
These sort of cognitive atrophy questions are going to be different depending on the human that we're talking about, but also the environment. Where are they? Because that also could make a very, very big difference. Like if the closest specialist is 500 miles away, That's a very, very different ecosystem maybe or scenario than if there's 3 specialists down the hall.
Exactly.
And then also maybe wrapped around this whole conversation is the organization that they may work for again, and just how diligent is this organization in pursuing revenue goals. Let me just say.
Yeah.
So maybe those are the 3 sort of factors here.
Yes. I think that the reality is, which is why you asked this question in the first place, is that I think, 70% of physicians are employed these days. It's, I think, more the minority who is practicing in rural America and doing everything for people. And a lot of people are beholden to these healthcare organizations where there's tremendous pressure on them to practice primary care in a very specific way, and there are consequences if they don't.
So let's just focus then on the 70% who are employed. They're employed physicians. Boss is the health system, maybe a little less often private equity, but let's just put them all together here. Is it inevitable cognitive atrophy or is it a needless inefficiency?
I'm going to speak in terms of risk because that's what doctors do. Like, there is a clear risk if you have physicians spending their days engaged in mindless activities that they will lose the skill set that they possessed when they were at the peak of their training and competencies and aptitude. Do I think that risk is inevitable? No, because that risk is conferred by systemic constraints. It is not inherent to the individuals who are practicing primary care. I mean, obviously, we're all human. There are going to be issues, in any profession. But what I'm trying to say is that there's nothing inevitable about a 15-minute visit. There's nothing inevitable about the way we've decided to measure quality in primary care. There's nothing inevitable about the way we pay primary care doctors. I could go down on and on and on in the list, but none of these things are inevitable. They were created by us as a health system, and then they have been tolerated by the profession, culturally, and by society. I say society because I don't think that we can look at the evolution of the healthcare system and our insurance system and just pin that on the profession. It is on some level a reflection of societal preferences over time. But I also think you can look at a moment after what happened with the murder of the United Healthcare CEO and realize that a tremendous amount of people hate our healthcare system. I always have a little bit of reservation being society wants this because it seems like they don't really want much of what we're giving them. But for whatever reason that I can't fully understand, we haven't summoned the will either within the profession or the public to dramatically change the way we're doing it. And some of that might be just because it's too complicated and it feels inevitable. So I want to emphasize that it is not inevitable.
We get what we pay for. And if we don't switch up what we're looking for or what the potential of primary care is, and then enable that, incentivize that, then we're getting the downstream of that. And one of the downstreams is we've got primary care doctors. There's absolutely no way they're going to be able to work at the top of their license.
I think that's fair.
Let's move on to our second. Is it needless inefficiency or the error of our ways coming back to roost? Or is this an absolute inevitability? It has to be this way. So the second one is, are we looking for from primary care a full spectrum clinical scope, or are we looking for referrals? A lot of times right now, what the sort of critique is that primary care is a loss leader, that is a referral machine. If you are a health system, primary care is considered a gatekeeper or a gateway, and you buy up all the primary care practices in an area. This is Health System Playbook 101. And then you use them for referrals.
Right.
And there is a in-network referral metric, and the more the better.
So that just comes down to also basic, I don't know if I should call it economics, but if the incentive exists at the system level, so you get, X amount of dollars for a primary care visit and X plus 100 for a specialist visit for your system, then you will always be creating a system that favors that specialist referral. Now, is that a bad thing? I think that's actually a more interesting question. I'm obviously a specialist. I think there are a lot of data that are all observational that suggest that when you have a higher density or a higher ratio of primary care doctors to specialists, and in areas, your overall like health outcomes improve. Those data are old. I don't know if they would still be true. And I think that, the more that primary care is whittled down to this bare bones algorithmic type of care, and the more specialist expertise is not just coveted, but coveted for a good reason. For instance, a patient can't get like an aortic valve replacement, by a structural cardiologist unless they get to a cardiologist. So I think it's easy to poo-poo like referrals, but some of it probably has to do with the fact that our specialists can do a lot of cool things that help people live longer and healthier lives. So I want to be careful about, like, we don't need to bash anybody in this conversation, but I think there is a clear incentive on a structural level that favors specialty care over primary care, more holistic management of complex patients. And that there's nothing inevitable about that.
How do we fix that then?
I think you just have to increase the amount of dollars going to primary care. So right now, about 5% of every healthcare dollar goes to primary care when they see about, I think, close to 35% of all outpatient visits. Nothing inevitable about that.
So is a, let's just say, not full spectrum clinical scope, is that inevitable that referrals are going to happen early and often, maybe a little bit too fast? Or is it a inefficiency or suboptimal in a way that we can fix? And if so, how would you fix it?
So I don't think it's inevitable. I think there's been a cultural and structural evolution forcing people to refer early unnecessarily. And I think that the flip side is that specialist expertise has grown over time. And I think we shouldn't, just for the sake of propping up primary care, pretend that like everybody should be doing valvular replacements and appendectomies. Like, I don't think that that's true at all. And specialists exist for a reason. I think there's a middle ground that we have lost. And we've lost it by encroaching upon primary care doctors' time and inserting a host of meaningless tasks that could be done by other people, if they're going to be done at all, that don't need to be done by physicians. And in that sense, again, I don't think that what we're seeing right now is inevitable, but I think we've lost the middle area where physicians, primary care doctors can do what only they can do.
The first thing that strikes me about the answer that you just gave is that it's not an either or at this juncture, that you can't say, oh, do you want to have a full clinical scope or do you want to refer? That the right answer is someplace in the middle, that there is a optimal moment when a referral happens for optimal reasons. The point that you're making is that optimal moment may become suboptimal if two things. If a primary care physician does not have enough time, and maybe just because the visit is short, or maybe because there's all kinds of paperwork, or, we often talk about this elusive team-based care, which is generally speaking a euphemism for
nothing.
Nothing much. The number of dysfunctional teams probably exceeds the number of functional teams at this juncture. And then what we wind up with is primary care doctors not performing the magic that they certainly can perform.
And I guess the one thing, we started out by talking about like, what is this expertise? Do primary care doctors even have an expertise? Because we tend to refer more often to specialist expertise. One of the biggest takeaways for me from doing the whole series is that there is expertise that lies in a relationship. And sometimes the best way for me to understand that is, again, through my own experience. If I see a patient 5 days in a row on a clinical service in the inpatient setting, my ability to make a decision for that patient on the 5th day is so different than it is on the first day. It's not something that I can calculate. It's a feeling. And I think that the fact that it's a feeling, the fact that it's a relationship, which sounds like so cheesy and not that important, has led to some of the diminishment of primary care. But to go back to this idea of what is that magic secret sauce that primary care offers, like they are the people who have relationships with patients over time. Does that mean cardiologists don't have relationships with patients? Absolutely not. A lot of specialists have relationships with patients too, but primary care, that is the foundation for us of relational expertise. If we lose that, we lose the judgments and the type of clinical excellence that is associated with being able to make decisions from within a relationship.
Which leads us to our third core question here, which is longitudinal relationship versus transactional throughput/fragmentation. So again, is it inevitable or is it a needless inefficiency? And it definitely sounds like you just gave a couple of great reasons why having a relationship matters. And there's been plenty of literature about this, also just the importance of relationships. You can't have trust without relationships. And as we all know, without trust, doctor can say whatever they want and patient may or may not actually do it or even hear it. Is it inevitable in this time-space continuum with AI and bots? And if anyone needs help, they just run to the urgent care. Like, there's a lot of reasons why fragmentation can happen. Or if they have 10 specialists, I read someplace the average Medicare patient has something like 8 to 10 specialists or something like this. Right? There's a lot of people that are involved in care. So is fragmentation then inevitable?
No, the fragmentation that we see results from a very myopic view of healthcare. So if you don't value the relationship, then you end up in these situations where by virtue of not having time or having had skill atrophy or whatever it is, you're just referring to a bunch of specialists. And the irony of all of this is that if we devoted healthcare resources upfront to the people who wouldn't need to be referring so much, I think there is a compelling argument to be made for investing in upfront, outstanding, holistic primary care. These start to sound like buzzwords, so I kind of groan inside when I say them, but I really do think that then the returns to the healthcare system down the road would be greater, but in years and years, like not immediately. And part of that investment is paying primary care doctors more relative to their peers. We have to attract really good people into the field for it to thrive. That's just how culture works.
Let's just say that the referral happens optimally. A patient who is at some rising or high risk still could wind up with 8 specialists.
Absolutely. But there are probably a lot of people who wind up with 8 specialists who don't need to be with 8 specialists.
Is it inevitable then that care is fragmented? Miriam Paramore wrote a great essay about this on LinkedIn recently, where her father needed a back operation. So he had his back surgeon. He also had kidney issues and cardiac issues. The nephrologist and the cardiologist could never get together and make a recommendation in a way that the orthopedic guy would take as an okay to proceed. Therefore, her poor dad was in terrible pain and could never get them all on the phone at the same time. It's like a downward fragmentation spiral. What structural fixes this? Is this, to your point, you said, figure out how to pay primary care more? Does that ultimately solve this, or is there more?
I think some of that, people are going to yell at me again, but like that's a cultural issue too. So that when I was talking about the moments that you can predict, so let's say I'm a consultant, I'm the cardiology consultant who needs to bless this patient for lumbar fusion or whatever it is. And why can't I pick up the phone and call the nephrologist? There's not a structural answer for that. There's a professional ethic that we have to uphold. And to get back to this moral injury thing, this is where I really worry about when we blame everything on the structure, we fail to see our own responsibility. And so I don't think this is not a primary care problem. This is just a problem of humans who are busy, who somehow have not internalized that part of our job is to communicate with all the other specialists and to close the loop. I mean, I think that's like the other thing. It's just part of communication 101 is like, I can't just send a message into a chat if nobody responds to it. I have to get on the phone. And maybe I need to do a phone call with everybody on at the same time. God forbid, maybe I need to talk to them in person. The other part of that is when you look at our demoralization as physicians, I think not doing that has contributed to our demoralization because all of these people are just, they're abstracted figures who are just like weighing in this way that has nothing to do with us. But like when you get them on the phone, you're like, hey, I'm really worried about this guy, actually. He's got coronary disease and he's got moderate aortic stenosis and his creatinine's 2. But at the same time, he can't walk and I don't see this getting any better. Do you think we should just bite the bullet and let him get this surgery? You share something in that moment. You're like, I care about this person. You care about this person. Now we're friends because we both care about this person. I just don't think that's a structural problem. I think the culture of medicine needs to pay more attention to moments like that.
So having gone through these 3, is it inevitable or is it a needless inefficiency? Probably the needless inefficiency is not the right terminology. It's something like, is this a structural or a cultural or a human? There's a lot of forces that have been inflicted on medicine really fast. And we've gone down some weird rabbit holes, and some of the fixes might be structural. Some of the fixes might not be. Some of them might be just like humans catching up with the reality of the situation and what our own responsibility and accountability and ownership is. You know, sometimes when cheese gets moved real fast, you sort of lose track of who owns what and who's the roles and responsibilities that there are. Not in all cases, for sure. And we certainly have these perverse incentives in the mix. So it sounds like our either or is on one side. Like, is this inevitable? Or is something that is fixable if we spend the time and energy to work on fixing it?
I wouldn't have written the series and done the podcast if I thought the state of primary care was inevitable. So I don't think that any of it's inevitable. I also think that what I just said, when you blame everything on the structural constraints around you, you become blind to your responsibility. Not everybody does, but I mean, you have to be able to talk about the structural constraints too. And I think in the case of primary care, the structural constraints are problems like 1 through 9. But for all of us in the profession, I do think that there will always be things that we just have to do because we recognize their importance, whether or not they're rewarded. And part of choosing to go into this profession is accepting that.
Really interesting that if everything can be blamed on some structural inevitability, that deepens the lack of agency, right? If we feel like there's nothing that we can do about it and therefore why try, that actually makes it worse and the feeling of being disenfranchised grows.
And let me just say, there are so many people who reached out to me who have found a way to practice outstanding primary care and to love it. And those people would not be doing it without their own agency. It's not like they practice in a perfect system.
There was a show a couple of years ago with Larry Bauer at the Primary Care Innovation, in the Primary Care Innovation Group. He wrote a book called 50 Bright Spots. We had him on the podcast. He talked about 3. But I think, you know, if you, as I'm distilling some of the insights that he had, it was very similar. It's just someone took it upon themselves to figure something out.
Right. I don't think there's any progress without that impulse alongside structures that can support true comprehensive primary care.
And advocating against those structures then is part of this also.
That is something that I hope for. I think a lot of primary care doctors are so far in the weeds that they're not out there advocating for themselves. They're advocating for their patients instead. But we're starting to see unionization, things like that. But no, I think we need to hear from them more. One of my ambitions was to collect their voices onto a podcast.
Is there any summary advice that you would offer either for physicians themselves who may be tuning in or those who are buying the services of primary care, of which we have a number who are listening right now, either trying to figure out how to do direct contracting or hiring on-prem primary care doctors or navigators, right? Do you have any thoughts or takeaways that you feel like it's really important for people to know?
I mean, I would ask every listener who's in that position of power to say, what do I care about? What do I care about for my doctors? What do I care about for the patients? What do I care about for society? Why am I in this business? Then I would listen to your doctors and their patients about what it takes to give that kind of care.
Sage advice. Dr. Lisa Rosenbaum, if someone is interested in your work, we certainly will link to this podcast series in our show notes. But is there anywhere else that you would direct anyone?
Well, I write. So NEJM.org. If anyone wants to read the essays I wrote on primary care, I think everyone gets 3 free essays a month. So even if you don't subscribe, you can read. And, but yeah, definitely listen to the podcast, not otherwise specified, wherever you get your podcasts.
Dr. Lisa Rosenbaum, thank you so much for being on Relentless Health Value today.
Thank you so much. It was really fun.